So, Dr. Marlies, I'll come to a little controversial question also. And I see the students prescribing a lot of soda bicarbonate in patients with AKI in ICU. So, where and under what circumstances do you consider giving soda bicarbonate in the treatment plan in your patient with non-oliguric acute kidney injury in ICU? What factors guide you in your decision making when you prescribe it?
It's a very important question. So a lot of patients with acute kidney injury need fluid therapy to correct hypovolemia and to establish euvolemia. A lot of patients are either acidotic or may have hyperkalemia. And in these patients, to either correct the metabolic acidosis or to help managing hyperkalemia, sodium bicarbonate is a very appropriate type of fluid. Now, the question remains whether sodium bicarbonate is better than other types of fluids. And this question is still unanswered, but I'm very hopeful because there are at least 2 randomized controlled trials trying to answer this question, one in France and one in the UK, looking at patients with advanced acute kidney injury, and they get randomized to sodium bicarbonate versus other types of other crystalloids. And I understand the trial in France has finished. So hopefully soon we will know whether whether sodium bicarbonate is more effective at correcting acute kidney injury and more effective at preventing renal replacement therapy. These are the 2 key questions in both trials, amongst a few other things. But do you improve the outcome, long-term outcome? Can we reverse AKI faster? And also, can we prevent renal replacement therapy, which is a fantastic therapy, but as we discussed earlier, also has harm and costs money and creates a lot of work for the bedside nurses.
True. Thank you for beautifully summarizing it. We are all waiting those randomized control trials to give us some results to show us how beneficial soda bicarbonate can be. Thank you so much, Dr. Marlies.
Dr. Marlies, next we go to the last question. We would like your inputs on a topic which is called as a drug dosing in CRRT. It's a very, very vast and expanded topic, but what general guidelines do clinicians has to follow when somebody is on CRRT and you have to prescribe the drugs in your ICU?
That's such an important question because we know, as you already said, that drug dosing is challenging when patients are on CRRT, and we have a lot of evidence now that patients are on CRRT are both underdosed and overdosed. So some patients come to harm from getting too much, and the drug is causing toxicity. But there's also now increasing awareness that proportion of patients may well be underdosed, and this can be harmful, especially if we're talking about antimicrobials for patients with severe sepsis or septic shock. So finding the right dose of any drug, but in particular antimicrobials, is essential. And this is challenging because obviously renal replacement therapy is a dynamic therapy where sometimes patients have unintended interruptions, or they may have planned interruptions in treatment, and the dose may have to be adjusted. So what I personally, if ideally, it would be wonderful if we could do therapeutic drug monitoring. And this is possible in some places in the world. And if that's available, then you can dose the drug accordingly. Sadly, this is not available everywhere, and it's certainly also not available to me. I don't have facilities to do therapeutic drug monitoring apart from gentamicin and vancomycin. With that in mind, I do 2 things. I firstly follow the ESICM guidelines, which are available on the website, but also as an app. And secondly, I work very, very closely with our pharmacists and seek their advice. And thirdly, I emphasize the importance to my colleagues, and particularly our junior colleagues, and inform them that if the renal replacement therapy prescription changes and there are interruptions, or we stop, or the patient has to go to the operating room, then I always remind them to seek advice whether the drugs need to be changed. So it's the collaboration with pharmacists and the guidance from the ESICM app, which at the moment help me getting through these challenges until therapeutic drug monitoring is available to everybody.
Thank you. It was a difficult topic always, but you're given clear answers. Team approach, teamwork with your pharmacy, clinical pharmacist, and that's an important aspect when you prescribe medicines in CRRT dosing. Thank you once again for the clarity in answer, Dr. Marlies.
It's also the other thing which is obviously important to collaborate, to learn from your colleagues. And I've learned a lot. There's a lot happening in India again, and I've learned a lot from colleagues in India about monitoring, about drug dosing, and the challenges. So again, I'd like to thank you for this great collaboration and joint learning.
Thank you once again for your wonderful session. We will wind up here. That's the end of our section. That's the last question.